get called a lot of different things. It's pretty simple to call them growth factors. They're housed inside the platelet in granules referred to as alpha granules. And when these platelets are stimulated or activated, usually due to injury or when we introduce them into an injured tissues or arthritic joint, these alpha granules release all these growth factors. There's several that we seem to talk about a lot. Platelet-derived growth factor probably is one that gets the most attention. There's some thought that it's involved in the initiation of all wound healing. And it also helps in replication, stimulates cell replication of stem cells and osteoprogenitor cells. And as many of these proteins and cytokines do, they're very involved in angiogenesis. And I think that that's important from the standpoint is that one of the commonalities of a lot of physical medicine modalities that I do, and now these regenerative medicines, is they all help improve circulation in the area. Transforming growth factor beta is really a superfamily of about 47 proteins, and they work on the fibroblasts and endothelial cells in the bone. You see a commonality too. A lot of these growth factors seem to really work not only on providing more blood flow to an area, but they're going to work with the chondrocytes and the bone-producing cells and the stem cells. Seem to attract stem cells. Fibronectin and vitronectin, I didn't know, I had never heard those terms until I started dealing with platelet-rich plasma. These get referred to as adhesion molecules. They assist in the movement of cells or the dispersion of cells through an area of injury. I think probably the best term that I've seen used is a cell scattering factor, where they'll maybe have activity to attract stem cells and then can scatter them through the tissues. And fibrin is also part of this. It helps with the mobility of the cells and also serves as a scaffolding. So it helps to trap the platelets into that area that we're trying to get them to work in, or that injured area of the tissue. When you injure yourself or our patients are injured, the body sends platelets there. So we're really doing a natural type therapy. We're just concentrating and trying to help the body in the healing process, and especially, and we're going to talk about it a little bit, but especially in areas of low blood flow, such as some of our tendons and ligaments. The additional factors, they're housed in dense granules that may play a role in some of the modulation and regeneration, ADP, ADP, calcium ions, histamine, serotonin, and dopamine. Did not really know that was associated with platelets. So let's talk now about platelet-rich plasma and what is it. As you're reading some of the literature, and when I was preparing for this talk, I went ahead and put together a paper that is going to be sent out to all of y'all that has all the abstracts that most of which we're going to talk about tonight, but some others that we aren't. They give you, so you don't have to write down any of these references. You're going to receive all of them. If you order some of these papers, some of which are free texts through PubMed, but if you order some of these papers, you're going to realize there is a lot of different definitions of platelet-rich plasma. There's not one single one. It's also known as autologous conditioned plasma, and that's the brand name that Arthrex has. But if we simply define it as any plasma product with a higher concentration of platelets in circulating blood, be it 2 times or 3 times or whatever it is, and that's probably one of the simplest definitions of platelet-rich plasma. One thing that I like is and this, I got this from a paper, is a milieu of bioreactive factors. Milieu or milieu, I may be pronouncing it wrong, is another word for environment. So what we're putting into a syringe and injecting into the arthritic joint is an environment of platelets that at higher concentration than those in the red blood cells, it's just full of bioreactive factors that we are going to refer to as growth factors. There's 2 basic kinds of PRP systems on the market. One of them is a buffy coat system. The buffy coat systems usually require 2 centrifugation steps or hard spins. Requires larger volumes of blood. The kits tend to be more expensive. You do, however, get a higher concentration of platelets. You get a 4 to 6 times usually. But with that, and we'll talk about the pros and cons of this, but with that, you get an increase in white blood cells as well as an increase in red blood cells. Your PRP systems, the plasma-based or the Iwrap system, is a simple, rather slow spin, 1 spin, that separates the platelets from the RBCs and WBCs. So as time has gone on and all these blood products have been used, everything from whole blood to different types of platelet-rich plasma, mesenchymal stem cell extraction, bone marrow, and all that, it seems like about a 2 times, maybe 2 to 3 times platelet concentration greater than whole blood is probably about the optimum. Realize this is a very fluid, ongoing research with papers being produced all the time. Basically hardly any in veterinary medicine, and the ones that are in human medicine. So we may learn in the future, we may learn many different things about platelet-rich plasma in dogs that we just have no idea of now, and cats for that matter. The higher concentrations tend to suppress cell proliferation, so more is not better. If we're going to compare that to a drug, it's a drug with a ceiling effect. Ceiling effect would be seen in a non-steroidal anti-inflammatory. Rimadyl may work wonders, but double Rimadyl has more side effects, potential side effects than benefits. There is some plus to white blood cells. I think our basic physiology taught us that white blood cells are going to go into an area and help debride tissue and potentiate antibacterial. Or potentiate an antibacterial response. I'm an old equine practitioner, and we used to heal a lot of wounds as open wounds, and for those first few days, that open wound is draining, and to the people it looks infected, but that's really the white blood cells coming in and debriding that tissue. And that's a benefit in certain types of wounds. And however, the neutrophils can also be catabolic, and they can increase the levels of some of the substances that have been identified to damage some of the tissues within the joints and tendons. The matrix metal proteinases are one of them. They can also have a negative effect on growth factors, and they can increase the catabolic cytokines within a joint and all that. So from the perspective that we're talking about tonight, we really want to try to have limited to no white blood cells in our product. An increase in white blood cells in PRP in the tendon will promote more scar tissue. It's going to promote less healthy tissue and less matrix synthesis, and you're going to get more catabolism of your matrix. So there's some definite negative effects in some of the soft tissues with the products that are going to have a higher white blood cell count. Matt, I can't see any questions on my screen, so if something comes up and I miss, would you let me know? RBCs and platelets are not beneficial either. They can release free radicals and inhibit platelet activation. And remember, it's that platelet activation that causes those alpha granules to release those growth factors.
Rick, I was muted, but there's no none of the questions came in so far. So if anybody has questions, just chat them in and we'll get them answered.
Okay. So what's the process? How do we do it? What do we do? Well, these are pictures from my office. Some were made today. Some were made a long time ago. But this is the basic process that we use. And I thought this would be beneficial to see what happens in a real-world practice that's not a fancy, sophisticated type situation. We do try to do a fresh, clean blood collection. We try to do that every time we draw blood. What I have done is I have assigned one technician to do everything from blood collection to bringing the platelet-rich plasma to the patient. And she's totally responsible for the record keeping and all these steps. And I think that's helped a lot. It's not that I'm opposed to teaching others, but this works best for me. She happens to be one of the most talented technicians at drawing blood. We try to use a large gauge needle when we draw blood, or our large gauge butterfly. We're going to use a 15 cc or a 20 cc syringe. We're going to put about 1.5 cc's of the ACD anticoagulant in it, and we're going to draw up about 15 cc's of blood when we do that. We do a
Rick, one thing.
Yes.
I was just going to throw in one thing and just get your comments on it. I talked to a vet today in Chicago who is using heparin instead of ACDA because we've had kind of a backorder situation, and he seems to think it's very effective for him. So I don't know if you have any thoughts on that.
I personally don't have any thoughts. I'm sure somebody may know a lot more about the differences between the two. I would think anything that would not allow the blood to clot and wouldn't lyse the blood cells would be fine.
Good.
We don't clip. I think some of the equine people do. I was a little bit surprised. And I haven't done a horse, but I was a little bit surprised because when you clip a horse, it's kind of a dead giveaway in the show ring or the racetrack that something's been done. But in any case, this is a hairy golden retriever, and we got a really good sample on this dog today. We take an 18 gauge needle and we introduce into the Arthrex double syringe device. You can draw blood with these devices, especially if you want to use a butterfly. However, they seem to be, from a practice perspective, a little bit awkward in drawing blood, and so the technique we use is with the syringe, as I mentioned, and then apply it directly into the device. Once we do that, it's set into the centrifuge. It's specifically made for that. When Rachel was initially working with me, I have a centrifuge that I did in-house stem cells with. We tried to put this double syringe in there and spin it down, which it did. We could set it at the same RPMs. We ran it through my automated CBC machine, and we got a much, much higher count of white blood cells, even at the same RPMs in the other machine. So kind of, I think if you decide to do this, you need to probably use the Arthrex equipment in doing it, and that way they'll stand behind the product. We're going to want to do this very quickly. I understand that horse blood and people blood can sit for some time with the anticoagulant in it before it's spun, but it's reported that you can have a number of changes occur very rapidly in dog's blood that can affect the platelets and also affect your collection. So we're pretty much going to draw blood and go straight to the centrifuge right around the corner and do that. We're going to spin it for 5 minutes at 1,500 RPMs. That's a pretty slow spin. Recently, we have disconnected or stopped the brake. Rachel stopped by and did that and said that we're getting a little bit, or that it seems to produce a little bit more plasma by doing that. It takes a little bit longer, but it really, in the scheme of things, there's so many other things you're doing during this time, getting your patient ready, that it really doesn't have any effect on the procedure. That's the separated product right there. We take that, and there again, my technician that's in charge will draw that up. And I've been visiting with her. I said, "How do you know?" And she said, "Well, I just know where to stop now." And she doesn't want to draw any red blood cells up in there. There's the finished product the double hull, and then the top syringe will unscrew from the bottom portion, and that's what contains our platelet-rich plasma.
Rick, I had a question come in.
Yes. Yes.
Let me read it to you. Can you have Rick comment on the effect of hydration status on the quality volume of the sample? We have found that we get better quality PRP in large volumes in dogs that are well hydrated. We have started to administer SQ fluids prior to collection or collect blood at the completion of the surgical procedure to take advantage of the surgical rate IV fluids.
Thank you for the question. We give IV fluids to every greyhound that we do. They seem to have a very, very low volume of plasma. Needless to say, if an animal were dehydrated, we would give fluids. Routinely, I'm doing most of these at my rehab center. They're not surgical patients, and we're not routinely hydrating these patients prior to surgery. But I don't see any reason why not to. And if you're recognizing you're getting an increased amount, then that's good. I think our collection process has improved with time, and we seem to get more and more. And it's amazing to me sometimes how the smallest dog can produce the most platelet-rich plasma. I can't figure it out. There's no way you can really tell. And when I'm visiting with clients, if we decide to do multiple joints, I have to tell them there's always the possibility we won't get enough. And if that's the case, we're going to administer the most critical joints first. But I would say our average from the Labrador Golden Retriever type dog is anywhere from about 3 to 5 cc without prehydration. But I think that could be a really good idea. In your surgical patients, and we'll talk about intraoperative use, but in your surgical patients, you already have them on your IV fluids, and I think you could do your collection perhaps after they've been on the IV fluids for a period of time and still have time. From blood draw to having the platelet-rich plasma ready in my clinic is about a 20-minute procedure or so. So it's not a very long process.
Rick, one other thing I wanted to clarify because I had a question come in. We initially had recommended 1,300 for a spin regime, and we're finding 1,500 is giving us better volume. So there was some confusion on that. I just wanted to put that out there for everyone.
Sorry about that.
That's fine. It's new.
Well, I think Rachel comes into my office and tells my technician what to do because she knows I'm not doing that anyway. So thank you for bringing that to our attention. This is a typical patient that we're gonna sedate these patients with dextometor, plus or minus a 1/4 milligram per kg of morphine. And then that makes for a nice reversal with antecedent. We've used that in old patients, young patients, and everything else. If I need to, we will put IV catheter in and run IV fluids, especially in a more geriatric patient. We're going to let them breathe oxygen. We're going to monitor their pulse ox during this procedure. And sometimes we're doing multimodal. This happens to be extracorporeal shockwave that we were doing prior to the administration of platelet-rich plasma. I'm one for sometimes maybe not the more platelet-rich plasma the better, but sometimes the more modalities that we can bring in that improve blood flow to a given area and help and release a growth factor, which I think the shockwave does as well. I think there's a synergistic effect there. I quit clipping for joints some time ago. That may be open to criticism, but I can tell you that I have a lot of good equine surgeon friends, equine practitioners that probably have not clipped a joint for injection in years, if ever. I think there's nothing wrong with that, and it's nice in a surgical patient that's already clipped. We do a prep, but in elbows, hips, and all the joints, we just don't do it. I don't clip for my epidurals anymore. And I just have not had a problem. I have a very good friend that practices up in East Texas, and I asked him to talk at a meeting on epidurals because I knew that he did a lot. I didn't realize he had records on 6,000 epidurals. And he said, I don't want to get anybody mad at me, but I haven't clipped after about 1,000, and he had not had a problem. So we do prep and clean and clip, and I'll leave that up for your discretion on what you do, but we don't do it. After we get into the joint and I get joint fluid, then I'm going to leave that needle in place, and I'm going to exchange that platelet-rich plasma with a syringe that we have a platelet-rich plasma. And I don't know if I missed, I want to go back here. I didn't talk about this. There's a little female-to-female device that we use to draw the platelet-rich plasma out of the Arthrex syringe, and they don't come in the veterinary kit. They come in my understanding, they come in the kits that the physicians get. So Rachel is nice enough to steal them from the physicians and bring them to my office. You can buy these. I actually checked on doing them in bulk, and they're not that expensive, but if your reps will you smile real nice and maybe they can steal them from the human kits, you can get them, but it's just a little female-to-female adapter. Sorry for the out of focus. This is a really interesting case. This dog had an avulsion of the greater trochanter. This is a Staffordshire Terrier with a huge gluteal muscle, and was swimming in a pond and pulling 3 kids in the pond as he swam, and came out and couldn't use the leg, and came to us from up in East Texas, and when we did x-rays we saw this avulsion. So we've been treating it. It's had its 2nd injection now. I think we'll probably do one more of this kind of infusion of that particular area. I've used an ultrasound for 1 injection, but you can kind of palpate that greater trochanter region. Putting a little bit larger volume. Normally we'll use about 0.8 cc's per joint. So what are the clinical uses in my practice? Well, to me, this is the meat and potatoes. This is probably why most of you came or are sitting in on a webinar tonight, is what do we do in clinical practice? The uses that I have are osteoarthritis is number 1. Soft tissue injury, muscle, tendons, ligaments is number 2. We're way behind in small animal medicine on recognizing soft tissue injuries with diagnostic ultrasound. Behind the equine practitioners, they're able to deposit substances right into lesions. I'm still having a difficult time finding musculoskeletal lesions with ultrasound, and I've been doing ultrasound for almost 30 years now. Musculoskeletal is very challenging. So I think as we improve as small animal veterinarians in our ability to find lesions in soft tissues, we're going to improve in our ability to treat those lesions in soft tissues. And then another area that I think for people who do a lot of surgery, especially orthopedics, is the intraoperative use of this. It sure gets used a lot in human medicine for that. An ear, nose, and throat physician in a surgical center across the parking lot from me uses it in a lot of his surgeries, as well as a number of orthopedists that I know. So I think it has a big deal. My surgical center is in a different location, and I can carry the centrifuge over there, and we need to start doing it more, but I don't always have it. But I think intraoperative use is just a really huge area with this product. These platelet growth factors, where they come into play with osteoarthritis, we're still trying to figure out all the pathogenesis of osteoarthritis, and I think we learn more all the time. But from an interarticular level, there's an imbalance of the regulatory factors that somehow or another within that joint that lead to the damage of the cartilage and articular surface. And, you know, age may be a culprit in that, disease, injury, obesity. Realistically, it's probably a multifactorial disease. Granted, we have the cranial cruciate ligament dog that ruptures their cruciate ligament, and the instability and the synovitis that maybe is the result of that is involved in the formation of that arthritis. But for the most part, these are multifactorial issues. The growth factors that are in the platelet-rich plasma then have the potential to really enhance the repair of cartilage or the slowing down of the progression. And right now, I don't know of really any good, there's basically nothing in veterinary medicine, but even looking at all the human literature that's going to say, yeah, these things are going into that joint, they're repairing cartilage. There again, they have the potential to do that, but right now I think we're benefiting from all the other effects that we know. These are those growth factors we're always talking about, and this is just a number of them. The platelet-derived growth factor kind of regulates the secretion synthesis of collagen. The epidermal growth factor helps in there again that angiogenesis, improve blood flow, improve circulation, the formation of blood vessels, cellular proliferation. Vascular endothelial growth factor is very, very important in angiogenesis. That gets talked about quite a bit when you read some of the papers that I sent you the reference, that we'll be sending you the references on. The transforming growth factor beta, this is probably actually a group of proteins, again, as most of these are, that stimulate proliferation of undifferentiated stem cells, and there again, the angiogenesis. The fibroblast growth factor, it's also known as beta fibroblast growth factor, or the basic fibroblast growth factor. That's hard to say. I'm having a hard time saying that tonight. Positive effect on cartilage repair. Well, that's definitely a benefit in our arthritic patient. And then the connective tissue growth factor, there again, improved blood flow. So this is what we're doing, I think, when we put these substances in. And we talk about these, and we talked about a few of these before. There's been over 1,500 proteins identified in platelets. And we really probably don't know which ones really are the most bioreactive, whether it's these or other ones. And we sure don't know in the dog which ones are the most bioreactive. We're extrapolating information from people. There have been a number of studies done in rabbits. We're also trying to extrapolate information from horses. So there have been some nice studies done in people looking at hyaluronic acid versus PRP. I think most of the studies that I've read are very positive from subjective patient evaluations, range of motion type situations, that PRP seems to have a significant difference over HA. There's one paper I read, there again, they're referenced below. They only saw a significant improvement with the use of PRP in middle-aged with patients with moderate arthritis. But overall, there seems to be, and the effects of PRP in people seem to outlast the effects of HA, and PRP seems to increase the production of HA within the joint in people. Our protocol is a dose of 0.5 to 0.8 cc's. The equine people tend to dose PRP at the same dosage that they dose hyaluronic acid. So if you kind of extrapolate that to a dog, I think 0.5, 0.8 is right in there. 2 to 3 injections. This number keeps going back and forth. We first started with 3 injections 4 weeks apart. Now we're doing usually 3 injections. However, I have some patients that we do 2, and we do them 2 weeks apart. I'm going to briefly mention Iwrap, not because I have any personal experience with Iwrap. Arthrex has an Iwrap 2 product now, and I think the representatives are much better at answering questions and discussing that. But there was confusion on my part when I started dealing with platelet-rich plasma. This is also referred to as autologous conditioned serum, which is different than autologous conditioned plasma. One of the big differences Iwrap, it is primarily a interleukin-1 receptor antagonist. That's a primary component in Iwrap. And I read a 2013 paper recently, one of your references again, where they really, in looking at this, felt that some of the benefits that were previously determined to come from this receptor antagonist type situation in the arthritic patient may not be totally due to that. It may actually be due to some of the other factors that are involved in some of the other products out there. So I wanted to simply mention that because you might get confused. This is what Kobe Bryant and A-Rod, I think, spent quite a bit of money in Europe. It has to be withdrawn, takes a larger volume, and it takes a period of culture time outside the body. And so not that the veterinary market has a concern, but the FDA doesn't allow that in people. You can do chairside withdrawals of blood products and turn around and inject them in people, and the FDA is fine with that. But when they do any kind of outside the body changing or culturing over any period of time, the FDA wants control of that. They don't allow culturing the bone marrow. Had some conversations with a physician in Denver, Colorado that has a clinic for bone marrow stem cells in the Cayman Islands. What's the difference? PRP has a lot of growth factors. Iwrap is basically a receptor antagonist. PRP is low in white blood cells. Iwrap, sorry, I misspelled that, is high in white blood cells, so it has catabolic cytokines, and the PRP seems to attract stem cells. There again. I think it's important if you're going to be doing products like this, or realistically, if you're in a pain management practice, you need to monitor your patients. And arthritic patients, the canine arthritic patient, is extremely difficult to evaluate the success of the treatment. So we basically have three different types of evaluations. We have the subjective evaluation, which is either from the client or subjective from the veterinarian. We also have what I call semi-objective, which is video analysis. Just simple video and looking at it in slow motion can oftentimes give you a little bit more information about gait patterns and lamenesses. And then you have the more objective assessments with force plate and gait 4, tech scans, some of the computer gait analysis systems. And I'm not familiar with the real sophisticated video systems that some of the universities have. But we don't see those in practice. I just got acquired a gate 4, and I also I've had a tech scan for 9 years. It draws a lot of dust in my clinic now. It's just kind of a cumbersome deal. I'm still learning the gate 4, and I hope to be able to employ that. One of the problems with arthritic patients is oftentimes, especially my referral arthritic patients, are multi-joint arthritis, and sometimes they wake up one morning hurting more in one joint than another. And trying to compare objective analysis of a force plate or a computer gait analysis can be rather confusing in the hip or the bilateral coxofemoral arthritis or bilateral stifle or elbows, and maybe all the above. So we tend to rely more right now on subjective analysis. The Cincinnati Orthopedic Disability Index is thought to be one of the more accurate. This way, the patient-specific functional activities can be identified by the owner. I just simply tell owners, list 5 things you've recognized a decline in your patient, what I call functional activities, and just grade them from no problem, a little problem, quite a bit, so on. And then there's also the standard orthopedic questionnaire where we're asking the questions of how they do these. And I tell them I don't worry about if they overlap. So if they put walking as one of their activities, they can still grade walking below. This tends to cross species. This can be used in cats as well. I was asked to come to the Houston Zoo, and we introduced this down to the Houston Zoo, and all the different zoo animals, many of which they can't even put their hands on to examine. And the zookeepers are basically the same thing as our owners, and the zookeepers are very familiar with their their animals, and they were able to relate to functional activities that the animals couldn't do anymore. They were reduced in, and so when they're treated with whatever methods for pain management, they could tell if there's an improvement. Tendon and ligament, most of this work is done in horses. The equine practitioners have a talent of guiding these in. Dr. Fortier at Cornell has gotten to where she identifies the lesions in these and actually fills the lesion with the PRP rather than a specific dose. And listening to some of her presentation, she's going to inject these lesions and repeat it, ultrasound in 30 days, and do it again if there's less than 50% improvement. These, both in people, I gave you a reference for a paper of Achilles tendon surgery in athletes, human athletes, and although the 12 people was rather small, the 6 people that had PRP introduced at the time of surgery of the Achilles, acute rupture of Achilles tendon, had a better range of motion, less pain post-operatively, and a quicker return to function. And that's what the equine practitioners have been reporting in these tendon and ligament injuries. Tendons and ligaments have pretty bad blood flow to them. And so we're injecting these growth factors into these injured tissues, and we're increasing the blood flow, and that's probably one of the big ways that it aids in the healing process, which brings about another subject of not wanting to suppress any inflammation these products might cause for a period of time after injection. 2 weeks is what has been told to us, where we're not going to apply ice or anti-inflammatories. You can understand if we're trying to promote a product that promotes angiogenesis, we don't want to do anything to counteract that. As I said, this is for those of you that do a lot of surgery. I think your fractures, your osteotomies, joint replacements, difficult wounds, there's just a ton of information from the human side about increasing wound healing. One of these papers, and I can't think which one it is, was non-unions. The mean time that they did these non-unions before, or from surgery to the time they introduced platelet-rich plasma, was about 42 months that these non-unions had existed. And after they induced platelet-rich plasma, they had healing in some within 4 months, and the rest of them within 9, and all of them healed. Now, there again, the numbers were very low for human studies when you're talking about, I believe this was 15 patients with 16 different fractures or non-unions. That's a huge study in veterinary medicine, so we're used to not having many ends in our studies at all. So that's pretty significant to me. What the hasten and healing, the recovery, that there's different papers on joint replacements, especially of the knee of people where the people are less painful, require less narcotics after surgery, and have a better range of motion and quicker recovery time when they have platelet-rich plasma intraoperatively. So that brings a point of questions, and I'm going to try to get out of this presentation and see if I can see my meeting. But if I can't, I'll leave it up to Matt to tell me if there's any questions.
So go ahead. If there's any questions right now, go ahead and chat them in, and then we'll get them answered. And send to everyone so everyone can see the question, please.
Yeah, Matt, I do not see mine.
Let's see. We got a question here. Can you mention the difference between stem cells and PRP?
Stem cells are undifferentiated cells that the idea behind them is that they're introduced into tissues. They basically, and I'll put it in common language, they take on, because that's all I know, is they're going to basically take on the DNA or the genetics of that injured tissue and become that tissue. That's the thought. That's the regenerative part of that. There's mesenchymal stem cells that are derived from adipose tissue and from bone marrow, and those are the ones that are used primarily in veterinary medicine. Every major hospital in the Houston area, for those of you who aren't familiar with Houston, we have a Texas Medical Center in Houston, which when you're coming in from different directions looks like another downtown. Huge hospitals. Every one of them have major stem cell departments. They're doing cardiovascular work, cancer work, and so on the horizon there's a lot of things that we're going to be seeing coming about by stem cells. Unfortunately, they have to go, well, unfortunately, as veterinarians, we tend to move on things pretty quickly, and we don't have the scrutiny that the medical profession has, and we don't have to go through the hoops. So we get involved with things, and right now the most common use of, quote, stem cells in veterinary practice is with adipose-derived mesenchymal stem cells harvested from fat in that patient. And there's not any of the companies, be it in the clinic processing or out of the clinic processing, that are doing any culturing to those, nor are they truly identifying the stem cells. So really what you're doing is you're injecting what is called stromal vascular cells, a portion of which may be stem cells. Now, if stem cells are to be effective, they're going to be much more effective if you know that you're injecting truly stem cells. But as also with the platelet-rich plasma, I think we're injecting protein and some cytokines and all those things that are also in these tissues. And so from a similarity standpoint, I think we're doing some of the same things. We were seeing 6 to 9 month, perhaps longer than that, improvement in many of my arthritic patients when I was doing stem cells. And if you remember, when I first started doing them, we were selecting the worst cases, and realistically, we probably should be selecting the best cases. But the promotion of stem cells was on this fact that they were regenerative. In other words, they were going in and regenerating the tissue. And after 5 years of doing them, and no proof that they were doing that, and getting now similar benefits out of platelet-rich plasma, which has that is said to draw those stem cells from the body into there, I think the platelet-rich plasma is in my honest opinion, I think it's more effective than the products that are out there being promoted as stem cells. But what's perhaps even more important is it's definitely more economical. When I quit doing the outside stem cells where I harvest the fat, overnight them to the lab and overnight, the cost to the patient was, with harvesting of fat and everything, was about $3,000, $1,400 of which went to the lab to process the stem cells. In-house processing brought it down to around $600 or so of cost for the kit and all that. So getting similar, what I think is similar results, we can do multiple treatments with platelet-rich plasma. We can also talk to the people that, you know what, we're probably going to have to do this again in this arthritic patient. And these are costs that don't scare them away. And I think we're doing much of the same thing. So I think a platelet-rich plasma is full of growth factors, full of proteins. One of the things we think it does is attract the stem cells into the area to help in the healing, as opposed to injecting an adipose tissue. Now, where the human market and where I think some of the best research is going, and I haven't looked at any really current papers lately on that, is in the cultured bone marrow. And I think, and I may be wrong, somebody may correct me, I think you can get those through Virginia. I think they have the DuPont Center that I think you can do that. I may be wrong. But where you withdraw bone marrow from a patient, you send it off. I think it's a several-week process. They culture those stem cells growing up and coming out. That appears to be where the best orthopedic benefits are from stem cells. So kind of a long answer to your question. I hope that helps.
Rick, are you seeing the chat box now? Because there's 2 more questions that came in. I just don't know if you see it or not.
No, I don't know what happened. When I went to my presentation, I apologize. I don't know what to push on here.
If you move your cursor up all the way to the top, there should be a little chat. I can read them to you, but
okay.
Let's see here. We got you mentioned the double centrifuge method of PRP collection and Arthrex's ACP single centrifuge system. Do you have any comment or comparison to the filtration system such as PAL's CPET system?
I don't know which system that is. I think right now, from everything that I can read, visiting with people and all that, that I want to deliver a platelet-rich product, a platelet-rich plasma product that has 2 to 3 times the number of platelets that are in circulating whole blood, and that has a very, very, very small amount of white blood cells and a very, very small amount of red blood cells. And so with my limited knowledge, that's not what you're going to get if that system is a Buffy-Coat system of the 2 spins. And it is what we appear to get if we're using the Arthrex system with 1 slow spin.
And the other question, Rep sent in, I had a doc interested in PRP for hip dysplasia. Do you have any indications for this, light, moderate, or severe?
I always make a distinction when we're talking about hip dysplasia versus arthritis, and if I can, let's define hip dysplasia as a genetic congenital problem with a laxity of the tissues around the hip, which lead to an earlier development of osteoarthritis. How platelet-rich plasma may affect hip dysplasia in the young dog, I think, is an uncertainty. Does it have a protective nature to it? Will it slow down the progression of the arthritic development? I simply don't know that. If the dogs are in pain as a young dog, I think there's all the reasons, because for reasons I don't think we totally understand, there tends to be an analgesic effect of platelet-rich plasma, even in the worst arthritic joint you've ever seen that you look at x-rays and don't even think has any articular cartilage. There still seems to be benefits of that. So in the young dog, there again, is it protective? Will it slow it down? Will it, if we want to get real optimistically, would it even prevent the development of osteoarthritis in hip dysplastic dogs? And I don't think anybody has a true answer to that. Will I use it in that dog? Absolutely. It is a very rare event that I ever use one modality in any one patient. I'm usually using multiple modalities, and so I would also recommend other things for a dog like that. There's a human study that I mentioned where the benefits of platelet-rich plasma exceeded those of hyaluronic acid only in a group of middle-aged with moderate osteoarthritis. I think it was of the knee, was this particular paper. I think those are really interesting, the differences there. I think you can find reasons to use platelet-rich plasma in every joint, and when I have a dog today that will be coming in next week that I saw for the first time with a ruptured cruciate, which will have surgery. But in addition to the ruptured cruciate, the dog has coxofemoral arthritis, also has bilateral elbow arthritis, and on radiographs, the elbows are horrible looking, but yet clinically, the dog is not that painful. When we collect the platelet-rich plasma, I'm not going to waste any of that, and I'm going to use it, if I happen to get 4 cc's, we're going to use every one of them. So there seems to be benefits from the growth factors, even maybe in the more severe arthritic joint. There are some papers in human medicine that suggest there is more benefit to catching the arthritic patient early with the platelet-rich plasma. But there's more benefits to catching the arthritic patient early with all of our therapies and treatments. And so I don't know if it's fair to judge platelet-rich plasma when you really read the papers. You know, they're not going in, they're not histopathing these joints to look at the cartilage and comparing the mildly arthritic patient to the severely arthritic patient. They're not sacrificing these patients a year from now looking at their cartilage. So there's going to be answers to those questions we don't have. So I don't necessarily draw a line anymore because I've seen the clinical benefits in all types.
And then a question I think that came out of your answer you just gave is, can you repeat what you said about using PRP and NSAIDs?
When we first started doing PRP, the information came from Arthrex to not use non-steroidal or any type of anti-inflammatory modalities, ice being the most common, for 2 weeks after we did that. The platelet-rich plasma actually creates some degree of inflammation, and we don't want to suppress that. I can't really reference a paper that goes into detail about what kind of inflammation these cause, but I think maybe the idea is if we're going to define inflammation as an increase in blood into a given area, then we do think it does that, and so we don't want to suppress. If that be the case, the NSAIDs probably would have very little effect on blood flow that I know of into an area, because you know, they are anti-inflammatory, but they work on inflammation in a different pathway. I still have made that a practice. We try to have them be off of their non-steroidals for a few days beforehand, even up to 2 weeks if we can, and then have them off their non-steroidals for 2 weeks afterwards. I still practice that policy, and we still do ice. And we'll send them home with written surgical discharge, as many of you do for all your surgeries, with those kind of recommendations, and probably discuss it with them as well.
Here's a question that I can say that they definitely do on the equine side, and so I'll ask you, Rick, if you do it. Do you freeze it and store it for later use?
No, I haven't. I've been told you can, and I can let, I'll be glad to let y'all make a comment if someone has a comment on that. I don't recall ever reading a paper about, you know, what it does. I mean, there again, there's that uncertainty. I don't think the costs are that much to just using a new kit each time, and so I'm not freezing it and doing it.
Right. The donor products that we offer on the equine side are frozen and shipped overnight, so right. We definitely know it is done.
Those are the products that aren't autologous, right? They're
they're taken from a closed herd of draft horses up in upstate New York. Any other questions? Oh wait, let's see. Here's one more. That's more of a comment. How do you balance the recommendation of using PRP intra-post-op with the recommendation of using NSAIDs or icing?
There again, I will be honest with you. I haven't used as much post-op. I don't do as much orthopedic surgeries as I used to do. I'm not a boarded surgeon, and there's just a lot of boarded surgeons in the Houston area, so I haven't had to face that problem. That's a good question, though. I can tell you that I am very into multimodal pain management, so NSAIDs are only one part of the pain management protocol of a post-op surgical patient. And, you know, in the future, as I begin to use more PRP in surgery for different kinds of surgeries, I think we'll just adjust our pain management protocol to avoid the non-steroidals and the icing. You can still do, in the orthopedic patient, you can still do your range of motion post-operative. In fact, we start that before extubation, the first series of range of motions before extubation. You can, the only place that I use a TENS unit, transcutaneous electrical nerve stimulator, is in the post-operative patient, the orthopedic patient. You can still use that. You can still do your massage. I don't think there's enough anti-inflammatory effects. I think those manage inflammation, but I don't think they affect the type of blood flow and inflammation maybe that we're talking about not wanting to suppress. So you can still do all those things without doing ice. If you're trying to avoid that, you can still do all those things without doing NSAID. You can still do your tramadols, your gabapentins, you know, and those types of drugs as well.
And then here's a question, kind of a follow-up question. Is PRP ever collected from one animal and used in a different animal? And the answer to that in the equine is yes, it is, because we have the donor products. Canine, I'm not aware of it. Rick?
No, I don't know any. I don't think there's any, unless some of the blood donors, you know, there may eventually with some of the blood donors, that may be something to look into actually.
Well, we have talked to our partners and for the donor products about doing it with canine. We just haven't gone down that road yet, but it could happen at some point. And then what about therapeutic laser post-surgical? That's another question.
We use it. You know, we talk about therapeutic lasers a lot in veterinary medicine because we're a wide open market, and we don't have the insurance reimbursement issues they have in people. And so they're promoted heavily in the post-op period as a management of pain. I think the way the laser, I have 3 therapeutic lasers, and I still question every day if they're effective in all cases. I think the way that they truly work is on soft tissues, and I think they help to improve the energy within those soft tissues by increasing the levels of ATP rather than trying to be anti-inflammatory. So I don't see any conflict, but I cannot recall seeing any studies either of any decrease or increase in effectiveness. There is one of the in-house stem cell companies that recommends, I think, actually directing some kind of laser light source at their product. And I've questioned that particular company a number of times on that and can't get any answers at all. So I don't see any reason not to use it if you're using it routinely post-operative and things happen.
And let's see, here's one that I get sometimes, and I don't really have an answer for it. Do you have any experience with feline and PRP?
I personally don't. There's no reason in my mind why it would not work. I think we totally miss pain management on cats altogether. In my primary care practices, we're just as bad as anybody else in discussing pain management. I saw a cat today for a referral for pain management. You know, cats and arthritis in cats doesn't always show the same as arthritis in dogs. Sometimes I think some of these cats are arthritic and you get very little, if any, changes on the radiograph. You get a lot of spinal arthritis in cats, and I don't know how we would necessarily go about injecting or exactly where we would inject with the platelet-rich plasma. But absolutely, if I had a cruciate cat were to come in, or you know, one with a coxofemoral arthritis, I wouldn't hesitate at all. I just haven't had the opportunity.
All right. Well, we ran about 12 minutes over, which is good. We had a nice engaged audience tonight, and Dr. Wall did an excellent job of presenting for us tonight, so we appreciate it. And if additional questions come up after this meeting that relate to this meeting, please contact myself, Lori Melhorn, and we'll get in touch with Dr. Wall, and we'll do our best to answer your questions.
Yeah, my email is on those things, and you're welcome to email me.
Thank you very much, Rick. Have a great evening.
Thank you. Bye-bye.
Thanks. Bye.